welcome to Book Beat. My name is Sue Ellen Zagrabelny, and I'll be your host today. Our guest is Senator John Marty from the Minnesota State Senate, and he's going to be discussing his book, Healing Healthcare, The Case for Common Sense Universal Healthcare. Senator Marty, thank you for joining me today.
It's my pleasure.
Let's start out by talking about the difference between health insurance and health care.
I think that's a good starting point because that's one of the problems we've had in our country with healthcare. We talk about health insurance, which is the system we have, rather than health care. And health care is what people want, and health insurance is supposed to be the way they access health care, but it's done in such a convoluted way that it's denying people access. All the discussion in many of the political debates, both in the state of Minnesota and nationally and in other states, is a discussion about access to health insurance. And you know, health insurance is not the same thing as health care, and I think that's a really critical difference. You can have health insurance, as most people do. 95% of Minnesotans have health insurance, but what happens if their tooth goes bad? Oh, it doesn't cover dental. Dental care, all forms of health care, mental health care, going to the doctor, everything that we might call health care. You don't have a guarantee of getting that just because you have a health insurance plan. And to me, I think what we want to do is make sure what 30, 40 other major competitor countries, if you're talking about 30 competitor nations, all 30 of them, except for the US, 29 out of 30, have universal health care. We don't even have universal health insurance, and I'm suggesting let's keep the distinction there because I don't think it matters if you have health insurance or if you have universal health insurance. What we want to have is universal health care.
That says it all to me, is the idea that you can't say health care without including that whole umbrella of the kind of care that you should get.
Which is why our system is so convoluted as it is, because we haven't acknowledged that that's the issue we want to address.
I think we've covered what's the difference between health insurance and health care, but tell me why the health care system and the insurance system needs to be healed, as you talk about in your book.
And I think the first point to make before you say about healing it is to say we've got some of the best doctors and nurses and dentists and chiropractors and pharmacists, some of the best medical education and technology, the best research. We've got some of the best in the world, not just in the US, but here in Minnesota, some of the best in the world. So the problem isn't the quality of the people providing the care or the facilities and the stuff providing the care. The problem is the system around that, and that's what has to be healed, because we have, despite the fact we spend literally twice as much as other countries of the world, and we spend more than twice as much as almost all countries. There are only about 8 or 10 countries that spend more than half of what we spend, yet our outcomes are worse. Our infant mortality rate, our life expectancy is shorter. We do worse despite spending all that stuff, and so it seems to me the problem isn't that we don't have good medical care, dental care available. The problem is the system of health care is sick, and we've got to fix that.
And the issue is access.
Access, and timely access, and the right kind of access, and all those things together, yes.
Okay. Where are we in that process right now?
I'm hoping as low as we can ever get. The system is, unfortunately, everything is being done in many reforms are making it more expensive, and they're making it more convoluted, usually with the goal of making it cheaper or better somehow. But when they decide we're going to try and do something, oh, this is going to improve quality. How are they doing it? Well, we're going to require doctors and nurses to spend more time reporting what they're doing. Well, time you spend recording and documenting and getting permission to do certain treatments, all of that is time you're not spending with the patients. And to me, one of the most valuable things medical providers can do with patients is spend the time, find out what's wrong with them. You can't just go into a room and, oh, this is your problem. You have to hear what they're saying. You have to figure it out. and use that medical professional's skills. But what we do in our system is we keep finding, we're going to find some new system that we're going to save money because we're way too expensive. And each time they do that, they seem to insert new bureaucracy and less time of the patient with the doctor.
Yes. Would you talk a little bit more about the process that
Sure.
that
Of how we came into this?
yes, yeah, because
Okay.
more or less the history of
Right.
this Michigas.
Okay. Yeah, and it's been, I'd say that the government, and at every level, it's not a partisan thing in any way, shape, or form, but at every level, there's been a huge problem, and we've been trying to address it for 40 years in American politics. One of the biggest problems is cost. It's way too expensive. We got to do something about that. And the theory, and it's a theory only, and it hasn't been very successful to address it that way, but the theory is that if something's more expensive, you buy less of it. That's what you would do in your household. That's what everybody does. If something's too expensive, you buy less of it. And the theory is if healthcare is too expensive, we must be using too much of it, so let's buy less of it. So how do we make that happen? We're going to work hard to make sure that nobody overuses healthcare, that they have skin in the game, so they're going to pay for it some if they're using it. And the theory is then that people won't overuse healthcare and the prices will go down. How do they do that? They've done it through what became called networks. Health maintenance organizations, HMOs in the 70s started saying, well, if you want to go to any doctor you want, that's going to cost you more. You can go to this network of doctors, this network of hospitals and clinics and so on, and you'll get better rates. So we're going to cover that better. So you've got in-network and out-of-network. That was one restriction. Co-payments, deductibles, those things, well, you know, if people have to pay this before they can even come in, well, then that'll make sure they don't overuse it. And if they have co-pays every time they use it, well, that'll help restrict it too. Then they started new things like prior authorization. Before a doctor can give you certain treatment or medication or something, they got to go to the payer, the insurance company, and get permission to do it. Not a medical permission, but an insurance permission, usually somebody looking at a chart and saying, well, in this case, no, we can't authorize that. Not a medical decision, but it's something somebody's making, so it's a little harder for people to get health care. After 40 years of reforms over and over again trying to make health care more difficult for people to get, we've been somewhat successful. The statistics show we go to the doctor less than people in most other countries. But we're still paying twice what anybody else in the world is doing. And I think that should raise two fundamental questions. The first is a moral question. What kind of a society wants to make it more difficult for its own people to get health care? That's a real moral question, because people do die because they can't afford to go to the doctor when they need. They put it off because I hope I'm not that sick. And they make poor choices because they don't want to overuse health care, or it's too expensive and they can't take the chance. But so that's the moral question. And the other one, the practical, common sense, economic one, is if we've been trying for 40 years to make health care cheaper by making it difficult for people to get, and we're spending twice what others do, it's not working. Maybe we need a new approach. And my argument is that's what we should be looking at. How do we make that new approach? And you look for models. What other things in society might you use as a model? And I'd suggest healthcare is something that we all need. You may need it 100 times more than me, or 1/10 as much as me. You can't know ahead of time who, well, if it's a child born with a severe heart condition, you're going to know they're going to be an expensive patient. But for most of us, we don't know if we're going to get cancer. We don't know what conditions we're going to face. So you don't know it, but everybody needs it to differing extents. Look at other public needs like that. Police and fire protection. Maybe your house is, I don't know, maybe it's more likely to burn than mine. Maybe you use electrical appliances differently, maybe other things. But we don't set up for police and fire. We have something that police and fire, you do not have to every year. Everybody gets it, but you don't have to. This is open enrollment time for health care. You don't have open enrollment for your police department? Open enrollment for the fire department? No, everybody's covered. You don't have to enroll every year. You don't have to shop around for a different plan every year. You don't have to pay a $3,000 deductible before the fire company comes. You don't have to ask your local sheriff if they'll cover your police insurance or if they're covered by it. You don't have to ask those questions. A civilized society thinks everybody deserves police and fire protection. I'd argue a civilized society, like every other country, thinks maybe everybody needs health care. So I'd say we use that model. That's what you start with. Look for a new model.
Okay. What is the reason Minnesota is a prime place to look at that new model?
Well, I think, first of all, I'd encourage every state, and the federal government ought to be looking at this because they're struggling. You look at all the proposals in Washington this year, the ones at the state capitol here this year, none of them are going to fix the healthcare system. All of them are tinkering around the edges. This year, Minnesota spent like $800+ million to try and stabilize the 5% of the public that buys its insurance through the insurance marketplace, MNsure. Trying to stabilize those premiums, $800 million, and nobody said it was going to fix it. They said, well, we're going to try and stabilize the market for 2 years. And they only put in funding for 1 year of it, but it's very expensive. And to me, with no other plan, any state should be trying this, but I think we're better equipped for it because first of all, we're one of the best medical care systems in the country. We have some of the best research institutions, University of Minnesota, some of the best providers like Mayo Clinic, and we have a relatively healthy population and people who are civically engaged and involved, and I think you need that in order to make a change like this. So I think we're well equipped for that. And so I've been trying to make the case, let's take a look at it. And so I started out not by figuring out, here's what we need to do, but start saying, where are we headed? What are the goals? I think anytime you're going to go on a trip, you need a map. You got to figure out where you're planning to go to. And so I spelled out some basic principles. I came up with 10 of them, but the basic types of things are, one, I think it has to cover everyone. I think that's what a good healthcare system does. It doesn't leave some kids out, like the school system says, well, you kids don't get to go to school. Covers everyone, covers all their medical needs. All the debate, pro and con, about the Affordable Care Act in the last 8 years, how much have you heard them talk about dental care?
Nothing.
Nothing. Absolutely. And I think healthcare ought to cover all your medical needs, not just eye care and hearing, but it should cover mental health and chemical dependency treatments, prescription drugs, dental care, everything. And dental care, it's a bizarre historical thing why that's separate, but you know, your teeth are just as important as your fingers and your toes. We don't have separate finger and toe insurance. Why do we have separate insurance for our teeth? Mm-hmm. But I want to make sure it covers everyone. That's another principle. A third one that I think is critically important is I think medical decisions and choices about this should be made by people, by patients. They should be choosing which doctors and clinics and hospitals they want to use. Medical decisions should then be made by those patients and those providers. The patient and doctor are better equipped to make medical decisions affecting that patient. You and your doctor are better able to make those decisions than some insurance company or government or somebody else. So we have 10 principles like that. Focus on prevention, make sure that it's something that everybody participates in, so the premiums would be based on ability to pay. I put together these 10 principles and then designed a healthcare system around it. And I like my healthcare system. I think it's a good proposal. But if somebody else, if you or anybody else says, look, I've got a better proposal, if it meets those 10 principles, which I think any good healthcare system should, I'll support it. I'll be glad to support it. I think if it's better than mine, I'll gladly support it. If not, let's figure out what's whatever. If it meets those 10 principles, I'll sign on.
Okay. How do you get from where we are to where we want to be? What vehicles?
Right. Well, that's a good question, and I mean, that's where the rubber hits the road. I mean, you can say, oh, I got a great idea, and if nobody's paying attention to it, nothing's going to happen. First of all, being in the state legislature, I put this proposal together about almost 10 years ago now when I was chair of the Senate Health Committee. And I had offered these principles up a decade earlier saying, you know, I think any healthcare system ought to meet these, and I was proposing to a governor of the other party And that governor's health commissioner, I had legislation requiring the health commissioner to design a healthcare system that would meet these principles. And of course, the bill didn't pass, so nothing happened. But when I became chair, I developed this bill working with a number of others, a lot of people trying to figure out how to make a healthcare system that works. Forget the politics, can it pass or not? What kind of healthcare system, what's a common sense healthcare system like? Design that proposal, and then all you have to do, and this is the quote, all you have to do, is get it passed through the legislature, get it signed by the governor. And that's the hard part. Why? Because there are lots of interests that make a lot of money off the current system, and they don't necessarily like it. So the trick is to take something that may not be understood by many, and that's got lots of opposition, and get it to move through the political process by educating people and so on, which means you have to sell the proposal. You have to let people, you have to explain why. How does it, because I argue my proposal is less expensive than what we're doing now, which is counterintuitive. So you got to explain why, explain that so they understand it. And then you got to tell them what's happening, why, what causes the politics of our system to develop such a messed up system.
Yeah, not to pick on the insurance companies, but to pick on the insurance companies at the moment. How does your system deal with the insurance company? Does it put them out of business? Does it?
It would. Well, it would effectively remove them not from auto insurance, actually auto insurance, the medical portion of it, which is a huge portion of your medical of your auto insurance costs are medical. When somebody's injured in a car crash or whatever, huge portion that goes to medical care, or a substantial portion of it. That would be taken over by the healthcare system, so your insurance for cars and so on would be cheaper. But they still have insurance for those things. But for healthcare, what we've got now is not a logical system. And if it's something everybody needs, you want to make sure, well, why are we having something where you got to shop around for it then? And the best way I can explain that, perhaps, and it doesn't just explain why insurance model is not a good one for healthcare, but also to explain why it's so much more expensive, is to use an analogy, and the one that people seem to understand best is compare education with healthcare. If we funded our schools the way we fund our hospitals, it would be a lot of changes for schools. Every teacher would have to spend half hour or more every day calculating time and resources devoted to each student, allocating it to them. And then they'd send it down to the school's billing office. And the school's billing office folded in all the overhead janitorial and capital expenses and everything else. And then they'd put it in a monthly bill to each family and their school insurance plans. And so families obviously have to go shopping around to buy school insurance plans. And because it's so expensive, employers would be offering employer-based coverage for their employees' kids' school needs. And then you'd have all these plans going and selling insurance to them. And the schools would jack up the prices in their bills, what a hospital calls a charge master, which makes costs about irrationally, but maybe 3 or 4 times higher because they know they're going to have to negotiate them down. And unfortunately, not every parent has employer-based school coverage, so then they're going to have an individual market to buy school insurance from. And because it's too expensive for a lot of those folks, you're going to have government step in and offer premium subsidies like the Affordable Care Act does. And it's a convoluted system, and a lot of the parents can't pay the co-pays and deductibles, so the school needs not only a billing office, but they need a collections agency. It would be a nightmare. Would it improve education? No, of course not. It would take time away from teaching, away from the stuff schools are supposed to do, and put it into billing, and take parent time that they could be spending helping their kids with schoolwork or being parents. They'd be spending, well, let's see, we got to shop around for health insurance each year. Now we have to shop around for school insurance each year. And can we afford this level plan, bronze plan or a silver plan or whatever? All that stuff. And in the end, there are other complications. Not every school is going to be in network. Some teachers in your own school might not be in network. And all of that's going to mean education's less good, less quality. Not every kid's going to get access to it, and make the system a lot more expensive. And nobody would suggest we need to do that. Nobody would suggest that would improve education or save money. And so that's the way I'd argue it. If it's something that everybody needs, and the amount you need varies wildly between people, even more than with education. I mean, special needs child and a child without special needs, there's a huge gap there. But between a patient without cancer and a patient with cancer, it may be 1,000 to 1 cost disparity. And insurance doesn't work in that kind of market. If it's something everybody needs, we should take care of it the way we do with education. Not provide it with all public schools, but have a system where we make sure that everybody gets it. We all pay for it, we all get it.
The universality of the health plan includes pre-existing conditions. It includes coverage of basically everything health related, not parceled out.
Right. Not in different silos where dental is in one category and something else is.
Yeah.
Right.
Okay. Where do we go? You know, considering the lobbyists that the healthcare and big pharma has, the issues, the PAC money that insurance companies and
yeah, you're hinting at, hey, aren't the odds stacked against us? And I'll have to say, they are stacked against us. But saying that means it's not going to happen, I'd argue we don't have much of a choice. What we're doing now is totally unsustainable. If you look what's happened now, Warren Buffett might be a good one to use, because he told his Berkshire Hathaway, his investors, last, I guess it was April or May or June, at their annual meeting, he told them, you know, the business community in the United States is always grumbling about corporate taxes. I mean, that's what they're talking about in Washington right now. Corporate taxes, he said, you know, in the 1960s, that was 4% of our national economy. Now it's down to 2%. And so he's not saying they shouldn't grumble about it and worry about it and so on, but he says it's about 2% of the gross national product. And he says healthcare was about 5%, and now it's 17% and growing. 17%. In most countries, it's down about 10% less than that. He said, he described healthcare as the tapeworm of our nation's competitive economy. It's eating away at the inside.
yes.
And so when you've got a system that is bankrupting the country, bankrupting businesses and families and killing people and all sorts of things like that, it seems to me that, yes, all those powerful interests who make money off the system as it is are going to fight very hard against it. But you know, if my plan doesn't pass this year, you know what I can tell you is? They'll be back. Because there's no other plan. I haven't seen any plans at the state capitol that have anything other than, well, we're going to temporarily try and fix this portion of the problem. They're not looking at the big picture of how we fix it. And this may be a weird way to describe it, but I'm going to make a pseudo quote from Winston Churchill. He didn't really say this, but it's a quote that was often attributed to him, and it makes the point. Winston Churchill allegedly said, Americans will always do the right thing after they've exhausted every other possibility.
Ah, yes.
And I say that because I think we're about the point where we've exhausted every other possibility. So yes, the odds are very heavily against it, powerful interests against it. But you know, we actually have, in the 1960s, American Medical Association and others, they were just 100% were against a universal health care system. Now, there was a poll in Minnesota about 10 years ago already, said about 2/3, about 65% of Minnesota physicians support a universal health care system like this. And the polls among the public, when they ask about it, it's not a government-run health care system, but it would be funded by a common fund where we all pay for it, we all get qualified for it, that the polls suggest almost 60% nationally support that. More among Democrats than independents, more among independents than Republicans, but even like 20% of Republicans say that we should go this direction. So it's not something that's bizarre. I think people can understand it. That's my analogy of the school to the hospital. People say, yeah, we wouldn't want to mess up our schools like that, and why do we have a healthcare system like that? And so I do think the times can change. And let me go further on that for a minute. A year ago, 2 years ago, there were no proposals for a universal health care system in the United States Senate. This past year, there was a bill introduced. It now has 16 co-sponsors in the Senate. And that's a huge change.
Oh, yeah.
And, you know, I can guarantee you those 16 aren't there. Oh, boy, they're championing this, they're championing this. One of Minnesota's senators signed on to it, but he signed on to it very tentatively sounding. He signed on saying, well, you know, Paul Wellstone always used to support this. Paul Wellstone authored a bill like that. And, you know, it's one option we ought to consider. Well, that's because they're afraid they're going way out on a limb politically. You know, they might be attacked. One of the things they will be attacked for, they'll be called supporting a socialist system. And I would tell those folks, you know, well, you know, when you supported the Affordable Care Act, which was an insurance-based model, came out of the Conservative Heritage Foundation, the idea, when you supported that, what did they call you? Socialist. It has nothing to do with socialism, neither does our universal system. But they call you that, so they're going to attack you for that. But the difference is when these 16 senators go out and say, well, yeah, we ought to consider this. I think they give a speech on this, and a lot of people, majority of people, kind of, about time somebody's talking about delivering health care in a logical way. And when politicians hear people say, I like that, and they applaud, they like to say that because they like applause. So they say it louder, and they get more applause, and they kind of become. So I think it begins to change the dynamic that they've been told this is unpopular and you can't do it. So I think that's where the public has a stake, even if they're not trying to be involved. When the public says, hey, this makes sense to me, I want to see that, I think it starts changing politicians' minds.
Yes. How does the general citizenry make a difference? What can they do to get informed? Where do they go to find out about this kind of issue?
Okay.
That I'm going to ask a bunch of questions and then you can pick and choose.
Okay, sure.
Where do they go to find out about these issues? Where do they go to find out about the interests behind the issue? And what can they do to get involved?
Okay. Good questions. And the first one I'll say is, I mean, your whole point of your show, the whole point of community cable television and so on, is to try and get more civic engagement in people. And I think that's the people who tend to pay attention to these things are interested in making a difference. They're interested in being involved. And this is one of the areas where they can. And I would argue they're already making some difference by saying, hey, I'm tired of this. And they do it, sometimes people do it by voting, but it's much more important earlier on to make the difference, to start changing the discussion in the community, changing the discussion at the legislature, changing the discussion in Washington, D.C., and making it so we talk about all these options. So first thing is, one, stress the importance of what you were just asking about. How do people get involved? Why should they? Well, they know why they should. This is a chance now they have to make a difference. How do they get informed? That's very difficult in general. Used to be, well, you can read the newspapers. Now, not many people read the newspapers, and there are thousands of sources of information, and a whole lot of the information out there is inaccurate. And related to that, your question, how do they know the sources behind it and everything else? When you listen to healthcare issues, healthcare debates, when you see the television ads on these issues, it's going to be funded by some of the groups who don't like it. And, oh, we're going to try and scare you that this change is going to be terrible. We're going to take away something you've got. And to me, I keep thinking, you know, people are scared, so that's a good political appeal to scare them. What you've got is going to be taken away. And I keep thinking, you know, that's one of the reasons it's important to talk about a comprehensive healthcare system, so that, I mean, the Affordable Care Act, one of the reasons it was unpopular with many, it's still popular with the majority of people, barely, it's kind of 50-50, but among the people who didn't like it, a lot of them were, I can barely afford what I got now, and now you're going to make me pay a tax if I can't afford it. And if my problem is dental care, and I can't afford to go to the dentist, now I'm going to have to pay for this insurance that doesn't cover dental, to me, telling them, no, we are going to cover all your medical needs, like the Veterans Administration does. It's like Medicare. I describe my proposal as Medicare Plus for two reasons. One is it covers everybody over age 65 and everybody under it as well. And the second one is like Medicare, but without the copays and deductibles, without the need for Part D and all these other part coverages, without all the limits on coverage like dental care, like certain types of care for things like lymphedema, for long-term care, nursing home care. It covers what Medicare covers, plus all the other medical needs people have. And saying we've got a system like that, it seems to me that that's the best way to get at people who are afraid. But your point was, yeah, they got to know who's behind these things, because a lot of the television ads in our political system are, virtually all of them are funded by interests that may not be the same interest as the person they're appealing to, and they may not be honest about what they're appealing to about anyway. So I'd say the best thing to do is find some organizations, Minnesota Nurses Association, various groups like that, that pay attention to healthcare, and listen to what they have to say. You don't have to agree with everything they say, but at least you know where they're coming from. And the other thing I'd say, like with this book, I made it clear from the beginning, I'm not going to make a penny off the book. I'm doing this to try and advocate for a logical, common sense healthcare system, and so they can download the book for free. It's just simply MN, like in Minnesota, mnhealthplan.org. They can download the book if they have a Kindle or Nook or e-reader of some kind, or just as a PDF for people like me who don't have an e-reader. But I want to make it accessible so they can get that source of information. And frankly, if you read it online, it's got all the links to our lives. You can see all the research that I'm using to document it, because that's one of the problems we have in healthcare is a lot of people claim I got the answers to this, but they can make up the numbers and everything else. That's
Or
why I
skew the number.
document it all, yeah.
Okay. We talked a little bit about where a person can go to find information. Now, my question is, how do they navigate advocating for themselves?
Right. And that's, I mean, it's interesting because under our current system, we talk a lot about navigating. And matter of fact, the federal government has funded navigators for the healthcare system. No, not for the healthcare system. They funded navigators to help people buy insurance, which is supposed to be their access to the healthcare system. We actually, under the Affordable Care Act, the MNsure, the insurance exchanges and so on, those are where those aren't healthcare system things. They are shopping centers for healthcare insurance. And we hire, the federal government pays insurance companies and advocates who work with low-income people, who work with people with language difficulties, other things. They work with them to help them find appropriate health coverage. It's important to have navigation help through the system, but I want to have people be able to navigate, you're having a problem with diabetes, or you're having a problem with this situation. Here's who you might go see. And if that's not helping you this way, maybe they can refer, or with back problems, maybe you, instead of going to a surgeon, maybe it would help if you could go talk to some physical therapist who could help you through this. We need to help people navigate the system, and so navigation is a key word here. And your question may not have been so much how do you navigate the healthcare system, but I wanted to make that point. But you're kind of, how do you navigate through the process of figuring out, this makes sense, I want to fight for that, I want to be an advocate for it. And to me, one of the things I would strongly encourage people to do is to look for organizations to advocate for things like that. League of Women Voters has been very supportive of this legislation, this concept. That's a good one to use. There's a new group called Healthcare for All Minnesota that's been advocating for a universal healthcare system. Physicians for National Healthcare Plan, they're primarily, the name says they're focused on fixing the problem nationally, but they've been supportive of something like this. So my suggestion is it's hard for you, the individual citizen, to say, how can I be involved? And I'm going to do this. And certainly we can all write letters to elected officials. We can call their offices, which is important to do. But it also helps to work together with others who share the common concern. So I'd strongly urge people to contact some of those groups like Healthcare for All Minnesota or League of Women Voters and so on and say, you know, I want to be an advocate for this.
Okay.
An individual. Should we start with that?
Yes.
Okay. Well, the plan would simply be, we call it the Minnesota Health Plan. I didn't want a fancy name, Minnesota Care, things like that. I just want a simple name that would explain it. Instead of having a various health plan, Blue Cross plan or such and such plan, and these Gold Advantage plans and this and so on, just a simple one. Minnesota, because it's for Minnesotans, and a health plan. It would be one that covers everyone, 100% of the population, for all their medical needs. They choose. Those principles would be legally binding on the health care plan. One of the principles is that they have to make sure there are enough providers around to meet basic needs, so you don't have waiting lines. And I think that's very important. So how does it work? Well, there would be a democratically selected board from county commissioners around the state would have local health, regional health boards, and they would elect from those boards, would elect the statewide board that administers the system. The system would then be the ones that negotiates contracts with doctors and hospitals and everybody on paying the bills. Instead of having 200 or 2,000 different payers paying into all the providers, you'd have one entity. It'd be the Minnesota Health Plan, would be negotiating with all the doctors, hospitals, everyone, and a logical way, because our current system is not logical. And they would be negotiating, paying the bills with them. So it would mean for the typical patient, it would be about the same thing that happens for a general medical visit. It would be the same thing that happens on, I'm still a few years away, but not that many, from on your 65th birthday. What happens? Oh, all of a sudden, you can still keep going to the doctor, the same one you go to, but now instead of somebody else, Blue Cross or somebody paying the bill, Medicare is paying the bill. And that's basically what it'd be, but it wouldn't be just for the doctor visits. It would be for the physical therapist, it would be for the prescriptions, everything else.
And it wouldn't be the 80-20.
Right, it wouldn't be 80-20. We would be replacing the premiums you'd pay to the Minnesota Health Plan would replace all the premiums, the co-payments, the deductibles, and everything else. And people say, well, then how high are those premiums going to be? Well, there are a couple of differences. First of all, you save a lot of money by having the efficiency. The illustration I gave earlier of the school system, how much cheaper it is to just provide what you want to provide, not have a convoluted bureaucratic system to fund it, but having a simple system, you save a lot of money. And then premiums based on ability to pay. If you're making there was one study of a plan similar to mine that suggested a median income household in Minnesota, which I think right now is about $60,000, would probably save about $3,000 a year. That doesn't mean their premiums would be $3,000 lower than their premiums now. It means that their premiums plus their co-pays, plus their deductibles, plus all their other out-of-pocket expenses for things like dental care, they'd be saving about $3,000 on that by the premiums they're paying to this, which would be all-inclusive. It's simple. It covers everybody for all their medical needs. So the system, it's a lot more understandable. The Affordable Care Act was like 2,000-page bill that people, it was the kind of thing doctors and lawyers, it's not for doctors, it's for lawyers and accountants and bookkeepers and so on. Our proposal, while it would get thicker when it goes through the process and you fill in all the details on funding and delivery and everything, but the bill as it is right now is like less than 30 pages, and I would suggest any Minnesotan without any internal knowledge of the legislative process or who's not a lawyer, and I'm not a lawyer, but they could read the bill and they could say, oh, I get how this works. And for the most part, you want a simple system like that. And so the system to the patient would look very similar, except you don't have to worry, is that doctor out of network? And if you've ever been in the hospital for surgery, I know I've been in the hospital for surgery, and when you find out afterwards, oh, the anesthesiologist was out of network. Well, I specifically picked the hospital and everything that was in network. Well, tough. And you're stuck with those huge bills. Well, you don't have to worry about any of those things. It's much simpler. You can focus on getting yourself healed. You can focus on your medical issues. You can focus on the rest of your life, not focus on how am I going to pay the bill? Is this covered? Uh-oh, how much extra is this? And obviously, that leads to the question, one of the big concerns, one of the challenges we have in convincing the legislature to support this is, well, how in the world are we going to pay for this thing? If we're spending twice what anybody else in the world spends on healthcare, and we only cover 95% of the people, and we don't cover a whole lot of things, how are you going to pay for all the new costs? And my argument is, it may sound counterintuitive, but it is actually cheaper. Why is it cheaper? Well, they negotiate prices. Why? Because you get rid of all that bureaucratic insurance and billing paperwork. Why? Well, just a logical healthcare system that gets people to the doctor when they need it can be cheaper. And there's two ways we know that. One is the real world empirical evidence on how much other countries spend on healthcare, what they're getting out of it, and what we're spending and what we're getting out of it. And then number two, there have been numerous economic analyses of universal healthcare system proposals in this country, and they all, no matter who's doing them, seem to point to the same thing, and that is that, as counterintuitive as it sounds, it's actually cheaper to take care of people up front and provide health care to everyone.
Exactly, exactly. One question I have is, there's got to be some bureaucracy to run the system. There has to be
Everybody,
an administrative framework.
Bills have to be sent and paid, yes.
Yeah, there has to be an administrative framework.
Right.
What would be different
Okay.
in the administrative framework of a common sense universal health care system and what's happening now?
Right. And to that, I'll go back, and this is a little bit, it's a little more complicated than what I'm going to say right here, but if you go back to the analogy of the schools don't need billing offices. Do they have bills that have to be paid? Yes. How does that work? Well, the principals and everybody meets with the school board, and they negotiate what the budget for each school is going to be. And then the school has got to live within that budget, and they have to figure this out. Well, but they don't need a billing office to collect co-pays and deductibles, and they don't need a billing office to send bills each month to all the families, and they don't need a collections agency to cover the stuff that's not paid, and they don't have to set these rates and then negotiate with all the different plans that pay at different rates for the same thing. You save all of that bureaucracy, but you still need somebody, and the difference here is the school, where it's simpler there, is that the school board runs the school, and that's also the payer. They just collect the revenue and they pay it. So it's simpler there. But if you have, and hospitals, we'd actually be doing the same thing. The health plan would negotiate a budget for the hospital. So instead of the hospital billing you for X number of units of fluids and X number of pain meds and X number of these procedures and so on, the hospital provides you the care, and every year they negotiate a budget for the hospital based on previous history, based on expected needs. And if there's an epidemic or something that just hits them hard, they renegotiate in the middle of the year. But so a hospital is actually the simplest place for it. If you go to a hospital in Canada or England or places like that, they may have, at least in a place like Canada, they may have a handful of billing clerks to deal with extra expenses and things that aren't covered otherwise and so on. But in a hospital, a 500-bed hospital there might have a handful of billing clerks. Hospital here with 500 beds has hundreds of people doing billing. So there is still the bureaucracy of who's going to bill the health plan, and for a doctor's office, that's where it gets a little more complex, but a lot simpler than it is now. A doctor doesn't just get a budget each year, a private practice doctor or physical therapist or dentist. They're told, okay, you're going to bill us how many, you treated these patients for this and this and this, we're going to pay you for that. But right now, every doctor's office, mine, suburban Ramsey County clinic that I go to, you walk in there, the first thing you do when you walk in there, there are like 5 clerks to welcome you in and get your billing information and collect your copay and everything else. The doctors simply have to record, okay, we saw these patients for these things, and the clinic has to say, we provided this many blood tests for this, and this many tests for that, and this many MRIs or whatever they're doing. They have to bill that to the system, but they don't have to figure out, well, is it in network, out of network, is it this plan or that, how much do we collect from the patient, what rate do we get paid for, because they're all negotiated differently. You have one billing entity and you send all the bills, and if you see 100 patients in a day at a clinic, you just send one bill. Today we saw these 100 patients with this and this and this, and these are the patients we saw, and here's what we did here. You send it in and you get your bill back. It's much, much simpler. But who would administer it? It could be the Minnesota Health Plan. We actually allow them the option where they could, and one likely thing they would do would be to contract with one of the companies that currently provides health insurance, because they already deal with claims. They need a lot fewer employees to deal with it because it's so much simpler. But it would be a bureaucracy to, you need anybody. I mean, any kind of business person has to have somebody who's dealing with the bookkeeping stuff, and a health plan like this would certainly have a lot of that.
Right. How would you keep the billing entities, ergo the insurance companies, that the now insurance companies?
What do you do for them?
Yeah, what do you do with them to keep them from, you know,
a lot of
golden parachutes and you know, irresponsible spending?
What they're doing, Well, a couple of things. First of all, right now we're in the middle of that, because Medica, which is a, quote, nonprofit health plan in Minnesota, because that's, until this past year, we required our health plans to be nonprofit. The legislature somehow wisely, unwisely, I'd say, in its wisdom, they thought that the idea of, well, let's allow for-profit insurance plans into the state, because life is so much better in the other 49 states where they have for-profit ones. So anyway, we allowed this year, I strongly opposed it, but we allowed for-profit companies to sell health insurance in Minnesota. And in the process of it, Medica is taking $120 million of its assets that came largely from the public programs, like from Medicaid and Minnesota Care, and from public employees. A lot of their assets came there, and we required them to have a reserve. Any insurance plan needs a reserve. And they built up these reserves with public money, and they just took $120 million of it and converted it in two different lumps. One to for a for-profit spin-off of theirs. They took this, and where's that going? That'll go in executive compensation, and their board, who made this wise decision that they enriches them all, they're going to do that. And another chunk of it went over to Wisconsin. And I thought, I want to treat Wisconsin fairly, but I don't want to give them our tax money just because Medica wants to spend the money there. And so that's what we're fighting now. But under our proposal, the health plans, first of all, because they're not needed for this, our biggest issue is how do we deal fairly with all their employees? Because a lot of those employees would be laid off. That's a huge obstacle. That makes a political liability in terms of passing to do this. I think we'd have a moral obligation that we haven't always done well as a society. When one industry gets pushed out of business, we don't do a good job of helping them necessarily. When Kodak film goes out of business, all their employees get hurt. Under this plan, what we'd be requiring the Minnesota Health Plan to do would be to pay dislocated worker benefits, retraining, payments to help them make their way through. We'd be providing that. It would be legally bound to provide those benefits and retraining to people who are being laid off. Not everybody who's laid off would need retraining. A lot of people who work in health insurance or health billing are already medical professionals and wouldn't need retraining. One illustration is Bill McGuire, the former CEO of United Health Group, the biggest insurance company in the world, health insurance company in the world. He's a physician. You know, he wouldn't need retraining. I'm pretty sure the Minnesota Health Plan couldn't match his $105 million a year salary, but he wouldn't need retraining. But there would be job displacement. And my argument is it would actually be cheaper to run an efficient healthcare system like the Minnesota Health Plan. And if you didn't want to lay them off, to just have people sit in their offices and do nothing, it would be cheaper to do that than to have them run this billing system, which means somebody at the other end has to do it, and the convoluted waste of everybody's time.
But I hope you're being facetious about them sitting in their offices.
I don't think that's a good idea, and that's why you want to provide retraining, and that's critically important. And the other thing is that this should be the best jobs creator. First of all, because there is a shortage of a lot of types of medical professionals. We need more of them. Everything from nursing homes trying to find LPNs, nurses, every level of nursing, there are shortages of people, and make sure those needs are met. So providing retraining for people to get in those fields. But the other thing is, what seems to be the case is that whenever you have a universal system like this, it's a far better jobs magnet, because businesses, Amazon, one of the reasons they are not likely to pick Minnesota, and one of the reasons they may be tempted to go to Canada, even though most of their market's not in Canada, is because they don't have to worry the same way about health care. And I actually suggested to the governor and state officials who were negotiating a bid for Amazon's new headquarters, I suggested, instead of giving them a subsidy, which other Minnesotans and other Minnesota businesses, including their competitors, are paying, why don't we offer them the Minnesota Health Plan? They'd have to pay premiums and so on into it, but it would be cheaper, it would be simpler, all their employees would be covered 100%, and on top of that, it'd be good for every other Minnesotan. And so, to me, the thing is that when you have employers not have to worry about health care for their employees, it's a humongous benefit to them in terms of creating new jobs. One more statistic on that. Last, I think it was 2010, shortly after the last recession, there was a survey done of 130 some employers in the Twin Cities of what their biggest obstacle to creating new jobs was, to hiring more people. Number one obstacle was not taxes or regulation or business or anything like that. It was the cost of health care for their employees. And to me, if we could fix that, we'd create so many more jobs. It helps those folks who are being dislocated from their current jobs.
And I think we have to be specific about the idea that when employers talk about the cost of health care, they're really talking about the cost of health insurance.
Right.
That doesn't necessarily have anything to do with health care.
Right. And they're paying, right now under our system, government actually, between state, federal, local government is paying more than half of our health care bills. Matter of fact, government in the U.S. spends more per person on health care than the British system does. In the British system, they cover basically 100%. And here we're covering a little more than half. So we spend twice as much as them, and our government is spending as much as their government is, but our system's so convoluted. So half the healthcare dollars are paid for by government. About a quarter is paid by business and about a quarter by individuals. And it's hurting families, as you know. It's also hurting businesses who can't afford that. And every employer, their human resources departments are twice as big as they need to be otherwise to deal with health care, health insurance, shopping for it, negotiating it, training their employees in what the changes in benefits are each year. Mm-hmm. That's bizarre. One executive at General Mills, a vice president there, a couple of years ago, he said something about how he summarized the situation we have better than anyone I have heard. He said, if you tried to design a healthcare system that didn't work, you couldn't have done a better job than we've done. And that really kind of hit the nail on the head. It's a convoluted system, and yeah, employers would be paying for it. We would have a payroll tax for employers to cover the employer share of it, but it would be less than they're spending now, and they avoid all the administrative hassle. Because right now under the federal plan, they are required, they have an employer mandate, and it's really, it doesn't just cause problems with cost and things like that, but it also is hugely discriminatory. Why do people, I'm 61, why do people in their early 60s have more trouble getting jobs with employers? Because if an employer has somebody, especially if it's a job where there are lots of people with the skills needed for the job, if they have a choice between somebody who's 60 and somebody who's 30, person who's 30, their health coverage is going to cost a lot less. Mm-hmm. And so they're not legally allowed to discriminate by age, but it's got to be behind their, subconsciously at least, it's affecting their decision making and hiring. So it's not only good for the employers, but it's fair to the employees too.
Yes. We're running to the end of our time today. And Senator Marty, is there anything else you'd like to add about your book, about the plan that you've put forward?
Sure. Sure. First of all, I'll restate that if people want to read the book, I mean, you can buy it online through Amazon and so on, but you can also get it, just download it for free online at mnhealthplan.org, like in minnesotahealthplan.org. And the one point I really would like to make sure we don't skip, and that is when I introduced the bill this year, we got like, I think 50 or 60 co-authors for the bill, and because of the leadership of the legislature right now isn't willing to consider it, we haven't been able to get a hearing. I've requested one, but we haven't gotten one this year, and I'm not sure I will next year. But I decided to have a news conference because I'm trying to make the case that, if they don't take it this year, well, they'll be back next year again because they won't have fixed the problem, and they'll be back the year after, and so on. And so I had a news conference, and the first question that came up at the news conference was exactly what I predicted to a staff person that I thought was going to be the question. The question is, isn't this government-run healthcare, and we don't want government-run healthcare? And my response to it was, if you think this is government-run healthcare, you haven't read the bill. This is the opposite. I don't want government-run healthcare. I don't want insurance company-run healthcare. I don't want employer-run healthcare. I want patient and doctor-run healthcare. I want medical decisions to be made by people and their providers. And then their comeback response, the next one after that, well, if that's going to be the case, first of all, they'll acknowledge, okay, then it's not a government-run healthcare plan. Government, maybe the Minnesota Health Plan, which is quasi-government entity, would be paying the bills, but they're not making medical decisions. You and your doctors and nurses and dentists and others, they're making the decisions. But then the second question, which is again scary to them, is despite all the economic evidence, they're convinced that people are going to go hog wild and they're going to get everything they can. And my response to that is, healthcare is not a consumer good, where the more of it we get, the better. Matter of fact, most of us feel the less of it we need and get, the better. We don't want to need it. We love our doctors. I mean, most people, if you ask who their doctor, oh, you're really a wonderful person. But they don't like to go visit them. It's not like, I tell you, oh, next Wednesday, I got the morning off. You know what? I think I'll go get me another colonoscopy because they're so much fun. People don't do that. We're not trying to go in and say, oh, can I have another hip replacement because that's so much fun. People aren't trying to get more care. And it's not like, there are plenty of other countries. They don't just cover it for themselves, but if you're visiting in their country and you get sick, they don't even bill you.
Yes.
And what's going on? How come they must have bills going through the roof if people can just take advantage of them like that? But the reality is they're spending half or less of what we're spending. And that should teach us something. So my point is that when people attack the bill, when they say, oh, it's government-run healthcare, no. What we've got now is insurance and government-run healthcare. No, ours is a patient and doctor-run healthcare system. And again, who's going to ration? Who's going to make sure we don't overuse it? And my point is the appropriate people to ration healthcare are not employers or government or insurance companies. It's patients and their doctors. And realistically, when patients and doctors spend time together, they make it happen.
Senator John Marty, thank you so much for joining me today.
Thank you for the opportunity.
And thank you for joining us at BookBeat today, the place for all things literary. We look forward to seeing you next time.